Good afternoon, ladies and gents. Just before we get started, I'd like to say thank you to MegaGen and the team behind Megamind. I think in a world where we all pulled apart, we need more events like this that brings the world together. So it's a big honor to be here, and I'd like to say thank you for this opportunity. Secondly, I'd just like to say thanks to my colleagues and mentors at the Implant Aesthetic Academy in Cape Town, Study Group 1. If you guys are watching, thank you very much. It means a lot, everything you've done for me. My role here today is not to show you a technique and tell you that this is the best. This is what you must use. This will win every case that you try. And I'm going to quote my colleague and mentor here: you need arrows in your quiver to win them. It's that person that can choose the best approach for that case that will win most battles. When we look at anterior aesthetic zone, the nature that we're trying to recreate, what is it that gives us this result? And it's not always the same thing. We need to do different things. Just like managing a football team, your tactic needs to be different to get the same result at the end of the day. So what's the formula? Well, it kind of depends what you're trying to achieve. I'm going to show you a series of 2 to 3 cases where we approach the cases differently to try and achieve the same ideal, natural result that we're looking for. Just like Mikhail, my colleague, spoke before, he spoke about everything about Socket Shield. Now I don't have to mention anything, thanks. That's okay. So in a single tooth replacement where there's a high aesthetic demand and the patient otherwise has a generally sound dentition, we want to look for a technique that's going to allow us to get as close to gold as possible. In a case like this, there's a failed apicectomy and it's a single tooth. There's only a little bit of bone. We know from Chapuis studies, Danny Booz's group, that in 85% of Caucasian patients, when you extract an anterior tooth, you will lose 100% of the buccal plate because of the bundle bone makes up the bulk of that bone. And so we opted for Socket Shield. I also utilize the Versa technique and the Versa burrs to osteodensify the site because not 100% of my implant is sitting in native bone when we're doing immediates. And so I want to osteodensify, and it helps me get that primary stability that we need. This is very, very important, the distance of the implant shoulder to the shield. I want sufficient distance so that I can get collateral blood supply, so that I can actually have bone in that area. I want bone there. I graft the jump gap, and then I use the patient's own tooth as a provisional where I can, because I don't get a better provisional than that. And I use an index for that. Su et al. In 2010 spoke about critical and subcritical contours, and Gomez Meda in 2021 followed up on that, talking about the biological and aesthetic zone. And this is the S-shaped curvature of your provisional. Your provisional is going to support the tissue around which you're going to get your aesthetic result. So this is the patient's original tooth. I've added some composite to build a connection onto the titanium cylinder, and I've seated it, and I've taken it out of the bite. Yes, it doesn't look great, but the patient's got a tooth. I want you guys just to follow. Look at where the gingival margin is in relation to the composite, and after healing. Can you see how we've got gingival creep there? This is because we've got an optimal design of the provisional restoration, and the tissues are responding adequately. It's like holding a plastic bag with water in. You put pressure on that plastic bag, it molds around your hand. This is what the soft tissue is going to do as well. We then can scan the original tooth with our scanner. We can get very fancy now. We can do just almost anything these days with digital dentistry. And we can manufacture an almost identical provisional to place into that site. And that's the provision. This is a provisional restoration, by the way. I don't do any of my own final restorations. I work as a referring practice. So this case is now ready to refer back and restore at my restorative colleagues. What about adjacent teeth? Two adjacent teeth, high smile line, demanding patient. What are we going to do here? Well, in these anterior aesthetic zones, there is, to my knowledge, there is no technique that will allow us to preserve 100% of the buccal bone after tooth extraction besides partial extraction therapy. And so once again, if I can manage to utilize the remaining root, and I can foresee that I'm going to be able to place the implants in an ideal position so that socket shield is the way to go, then that's what I want. Here we had to do a apicectomy bilaterally as well, get rid of the infection. We placed, and after we provisionalized, that is the result, and this is 3 years later. That amount of buccal bone, at least in my hands, is possible because we are preserving bundle bone and that very, very thin buccal plate. What happens if we can't use the shield? Because I have cases, I have patients that come and now we can't do a socket shield. Well, not all is lost. We need to remember to look at the case as a whole. In this case, certainly, we opted to do some clinical crown lengthening. The patient was hesitant to do a lot of treatment. The patient came to me and wanted a single tooth restoration. She needed crown lengthening and she needed 2 crowns. It was difficult to get the patient there. I couldn't carry out socket shield, and I opted for a surgical veneer graft. And this has proven, at least in my practice, to be a very predictable approach as well to these cases where we need some augmentation, almost to preempt the inevitable cascade of physiologic events that will follow tooth extraction. And this is where we land up. A lot of this result depends on us getting the emergence profile of the crown correct. And a much happier patient ready for final restoration. Now, what about when we get complete loss of tissue? I send it to one of my friends over here. These guys all know how to do this. Just want to run away. This is a young 23-year-old patient that had her lateral extracted somewhere, and she came to me for an opinion after they said they can't place an implant there. And I said, well, they're right. You can't, not at this stage. The other problem is that we've got teeth without bone on either side. This doesn't give us a lot of hope. Have a look at the CBCT slices. We don't have a lot of buccal bone here. We've got nothing over here, very little over here, and nothing interproximally. I opted to extract those teeth because I couldn't predictably and reproducibly graft that area with avascular root surfaces on either side. But now we're left with a massive defect. Tough one, tough one. Just want to run away. Just to give us an idea of what we had to achieve is, and I like doing this often, is I just mimic what's happening on the other side and I try and draw it in, and it kind of gives me an idea, kind of guides me as to what I'm actually missing and what I'm trying to achieve here, because it speaks to the kind of techniques that I want to incorporate. And obviously in my mind I'm thinking curry plate, and I'm thinking this, and I'm thinking that, and curry plate, yeah, that's the way to go. And I take a CBCT, and guess what? She just actually doesn't have bone. Nobody ever speaks about that. I want to do it, but what when there's no bone? So I did something a little bit unconventional. I used GBR using OSSX membrane lasso technique as described by Neva et al. Although this is for fenestrations, not for massive grafts like this, but this is what we had to work with. Grafted, and after grafting, can you see how we are already starting to head into the right direction? We're not anywhere close to where we want to be, but at least we headed there. The next thing that I wanted to do was I wanted to place the implants, and I wanted to do some soft tissue augmentation as well. So I incorporated the VIP-CT graft described by Misha et al. In 1999 and modified by Dennis Tarnow the following year, where he described this tunneling underneath. And this will give us good tissue bulk in this area. And now we can start developing that site. So we went from this to that. No pink porcelain. Is it perfect? Not perfect. Are there things I'd change? Absolutely. I've been doing this 5 or 6 years. Every day I do it, I think I know less and less about implant dentistry. But we've given this patient her teeth back in the anterior aesthetic zone. We incorporated a lot of techniques by a lot of clever people, and we provided her with some kind of result that I was quite proud of. If we look at the cross section, good bone. Will it be like that in 10 years' time? Who knows? I hope so. Thank you. This is